Part 5, withholding versus withdrawing. What's the difference? Well, withholding, you never start the treatment. Withdrawing, you end and remove the treatment. Many people find it easier to withhold than to withdraw. Withdrawing feels different, but emotionally, legally, and ethical, it is neither better nor less than withholding, less risky than withholding. Many therapies require a short clinical trial to determine if the therapy will actually be effective. So you have to start the therapy before you can decide if you're going to stop it. Modern therapies that promote comfort should be continued even after curative therapies are stopped. So at the end of life, we're going for comfort, pain control, no anxiety. Those are the big ones. So we want to make people comfortable. If we're giving them therapy that improves their comfort, it will be continued. If we're giving them therapy that we hope will cure them and it's not, that can be withheld. Now, autonomy versus beneficence. Remember we talked about beneficence, do good. And then autonomy, letting the person make their own decision. How do we handle hydration? Hydration and food. How do we handle that? Food isn't medicine, right? But delivery of food through a feeding tube is a medical treatment. Infants, disabled, some elderly are often given feeding assistance. Culturally, food, almost universally around the world, food is viewed as a caring and a hospitality and comfort. How many times have you gone home or to a family's house and they say, let me get some food out. They'll bring food or beverages out. That's what we're taught to do. So now we're going to stop giving them food and fluid? Just because the person wants it? How is that me being good? Well, you're being good because you're allowing the patient to choose. Artificially provided nutrition and hydration is considered medical therapy that ethically can be withdrawn. I've seen it happen. And a lot of times, the patients are okay with that. End stage, they neither want food or can handle food. They don't really care about fluids. I've seen it myself. Maybe you have. We want the patient to drive their care as much as possible. If they say stop, stop. Because what's the difference, really? What's the difference of stopping giving them tube feeding versus them saying, I'm not going to eat anything anymore, and they just stop eating? It's the same thing. So if they can say, no food, no water, nothing. If they can say that, and they can, why can't they say, get rid of that tube? Many dying people actually lose a sense of hunger and thirst as death nears. Voluntarily stopping eating is a sign that death is coming. Now, it may not be for a while, but when a person stops eating and drinking, you can take that as a major sign that death is not far off. It is legal. It is not a form of suicide. Usually death will occur in 1 to 3 weeks. If the person continues to take fluid, it'll take much longer. Now, that sounds like a long time. I've seen it happen. It takes a long time. While you're doing this, you're going to be giving medicines for anxiety and pain because that's still comfort. It's not curative. If you ever work for hospice, you will become a nurse of relief. You will provide pain relief, anxiety relief. You will provide comfort. We're not going to cure anything. Hospice nurses are true angels on earth. So tube feedings may be useful because they decrease the discomfort if a person has problems swallowing, can prevent choking. But it doesn't necessarily decrease the incidence of decubiti or aspiration or malnutrition. So tube feeding doesn't necessarily provide a great benefit. It can, but it isn't guaranteed. Now, antibiotics, what about that? in 2 studies, showed no difference in mortality between treated and untreated patients. 20 to 25% of pulmonary infections will be fatal. 20 to 25% of pneumonia cases will be fatal, treated or not. That is a big number. Antibiotics do not require consent. So if the doctor feels the antibiotics are appropriate, the doctor can start it. Now, if the patient says no, or the family says no, that's different. It does not require consent. Terminal versus non-terminal. Talked about that very briefly when I brought up the insulin and diabetes situation. Many people think that a person must be terminal before they get the right to withdraw life support, and they don't. They can stop that whenever they want. Competent patients, whether they're labeled terminal or not, always have the right to refuse any recommended therapy, including those that are life-sustaining. Similarly, incompetent patients always have the right to have a surrogate decision-maker participate in healthcare decisions in the same way as if the patient were able. So, at any time, a person can say, I'm done. I don't want to eat anymore. I don't want to drink anything anymore. It's not common. Okay, now, what about, let's think about this. If we allow a person to essentially starve and be thirsted to death, are we assisting in suicide? No, we aren't. There's a big distinction between relief of suffering versus killing or assisting in suicide. If the person chooses to stop eating and drinking and yet wants pain medicine, as they get dehydrated, their blood pressure will go down, their respiratory rate will go down. If they still have pain, they can have pain medicine. Now, what will that do to their respiratory drive? Could slow it down. Some people argue that the true intent of the patient is not death, but actually to alleviate suffering. So if they're saying, I want that medicine because I'm in pain, you need to honor that. It's a fine line. This is an ethical question. Again, has there been communication with family, with caregivers, with providers? Here's some more problems. Ageism. We tend to look at older people as being sick. Well, they may be. But a 75 to 79-year-old person has an average lifespan of 12 more years. So they could make it to 87 to 91, right? That's an average 75-year-old. If they can make it to 91, or if they can make it to 95, they have an average of another 3 more years. So they could actually make it to 100. So we can't use age as a determining factor on who gets what and who does what. And I have seen many centenarians in the Manitowoc County area. I'm not sure what it is. Is it water here or what? But there are a lot of people who are over 100 here and still with it. What about advance directives? They don't save money. They're not designed to save money. People with advance directives spend less in their last year of life because they tend to have predictable terminal conditions. So if a person who has an advance directive, we know what's going on. You know, it could be advanced cancer, could be advanced end-stage Alzheimer's. It's predictable. When death is not expected, outcomes can produce higher costs, but not necessarily better results. Some places, Gunderson Lutheran over in La Crosse, shows that these protocols actually improve quality of life and reduce cost of care in the last 2 years of life. That is a win-win for everybody. Hospitals don't get paid for readmissions. I don't know if you realize that or not, but if you're taking care of a patient in the hospital for whatever condition, and they're admitted anytime within the next 28 days for whatever reason, that hospital will not get paid under Medicare or Medicaid. So these are things that need to be planned for. Nursing homes can get penalized for not recognizing and acting on changes in condition. So, advance directives they're not written with money in mind. The goal of healthcare professionals, of all of us, we want to make sure that difficult choices are made with full information. That we start the conversation early, like on admission, start talking about it. Make certain that choices are not made out of fear or distress or suffering, but with an understanding of what the end result should be. And if the patient and family continues to want to receive support and palliative care, even after the decisions are made to forego aggressive therapy, remember, palliative care is not curative care. A patient who is terminal with cancer may still receive chemotherapy because it's palliative. It's designed to reduce pain and suffering, not cure. That's it for part 5. Come back for the last one.